I thank the ROC committee, Dr. Ranawat team, for allowing me to present this case. He's a 57-year-old man, had a road traffic accident with acetabular fracture, and he was operated elsewhere. Within a month, he dislocated. It was close reduction done, again dislocated, and this was tried almost 6 times.
All right, so let's hold on right there. So let's start from the far end. What do you think the problem is?
Here it appears to be cup is in retroversion first. Second, and there might be loosening of cup as well for the dislocation.
What about the overall length of the construct? It's hard to say. We don't have an AP pelvis, so there's nothing to compare to. But my impression is that it might be a little short. Okay, so what did you do?
Yeah, for 6 years, he refused surgery and went into severe depression, lying down in bed with pain.
Dr. Mukhi, how long after the fracture was the THR done?
That was within a year. He got fractured, fracture united. They did the wrong surgery. It was malunited. Went for THR. THR kept on dislocating. He got fed up and he remained in bed for 6 years.
Okay.
This is a persistent dislocated hip.
Yep. All right, now we have a Crow 4. Okay, so how are we going to get it down?
Yeah, I mean, you have to, if it's mobile, if you can get it down, you have to be prepared to do a shortening osteotomy, but you probably don't need to do it right away. It's already dislocated. If you can get exposure to the socket, to change the socket, and then reassess to see whether or not you need to do a shortening osteotomy.
BJ, anything to add?
These recurrent dislocations are usually not stiff, so I don't see a problem in getting it down with the appropriate releases. The cup, I would revise it to dual mobility. I will retain the stem. I'd use the appropriate combination and I'll do a dual mobility on him.
I still think that you are right. It does look as if the overall reconstruction is shorter.
Yeah.
And that has to be seen whether we can add more neck length or not. Otherwise, we may need to revise the stem.
Yeah, well, I mean, I think first you got to get it down, and then you got to get it longer, right? But I think the key to this operation is the same thing as when you do a Crow 4. You have to release the entire soft tissues around the proximal femur.
360 degrees.
360, with the exception of the gluteus medius, right? Everything else, and you got to literally take it all the way this way and take it all down. So let's see. And then did you do an infection workup and everything else?
Yes, that was all normal.
Okay, good. Finally, one case that doesn't have sepsis. Okay. So?
I did the CT scan.
Okay.
And
what's the version of the cup?
Version was little more inclined. It was more vertical.
Yeah.
And it was, otherwise there was no anti-version.
It was neutral.
Neutral.
Okay. So, but I think the cup is well fixed, right? So I think, there are lots of options here. Whatever the company provides, with regards to, 10-degree or 20-degree liners.
Elevated liner here
right?
can be.
So you have that option. You can cement in a liner in a better position. So the cup is well fixed. You don't have to rush into revising the cup, is my point. It's an option, obviously, but there's...
Yeah, that is the indication for the augmented liner, if cup is well fixed, yeah.
Yeah. All right, so what'd you do?
I went in, I did the abductor weakness test because the acetabular fracture, whether the superior gluteal nerve was also damaged and could be the cause. Kept dual mobility cup ready, kept the longest head, large head, extraction instruments, and a distractor. And I found on the table the cup was too vertical and this hip was reducible, but it was dislocating. So what I did is I changed the cup. The stem was normal, and I did the collinear test on the table, and I took the X-ray on the table, Shyam, and I was convinced that I got the tissue tension, The Dr. Ranawat's test, collinear, was very good. And I did grafting over there, tried to take out as much cup as possible, and did poly on oxenium.
Did you think about taking the 20-degree liner and putting it more superior? I mean, the cup looked vertical on the X-ray, but it didn't look that vertical. It wasn't more than 52 to 54 degrees. So, I mean, I think, it's... Again, I'm not sure that jumping to a cup revision is necessarily the answer.
It was
But
short.
show us a real X-ray.
Yeah.
So he used a skirted head, so it's used a longer head now.
Yeah. That was also,
Did you say oxenium?
yeah.
You put oxenium on a Korea stem?
Yeah. It's not a coral stem.
Then what stem is it?
It was the Deepui stem only.
Yeah, but it's a
no, it's
oxenium
not-
is on Smith
But it's
and
still
Nephew.
not a Smith and Nephew.
It was the old stem.
Yeah. So you never mix those. That would be indefensible if something happens. So you should not mix companies,
Yeah, one company's 1214 is not necessarily the other company's 1214, right? So yeah, in general, I think, are there circumstances that I have done that? Yes, because sometimes the hip world is so crazy. But in general, we should not, as teachers, advise you to mix companies' parts, right?
Right. It doesn't stop here. He started walking. He was good. He came for the knee replacement. He was very happy. And then 4 years, 7 months, and he was absolutely free when he developed a fracture of the spine, and he wanted no one else to operate, and he was weak in both the legs. Not total paraplegia, but paraplegic. And I had to operate on the spine also. And this is what his result is today. At 2 years, this is the result.
Good. You saved him.
Yes, I thank you for your attention.
Excellent.